Welcome to the webinar, Thinking Outside of the Socket Grafting Techniques. This lecture will be presented by Julia L. Jackson, DMD, and we will begin shortly. And with that, it is my distinct honor to introduce Julia L. Jackson, DMD. Dr. Jackson, a Philadelphia native, earned her DMD from Temple University in 2005 and completed her oral and maxillofacial surgery residency at Howard University Hospital in 2011. She has since practiced in Pennsylvania and Virginia, specializing in advanced surgical techniques and implant dentistry. An active lecturer and member of professional organizations, Dr. Jackson founded 2 study clubs in Virginia and serves as CEO and founder of the International Implant Institute in Northern Virginia, where she advances education and innovation in implant dentistry. And it is my pleasure to say, take it away, Dr. Jackson.
Thank you, Jessica. Thank you very much. I'm so delighted to speak with all of you tonight. I love oral and maxillofacial surgery from the bottom of my heart. And Jessica's right. I did go to Temple Dental and I did 2 years of oral surgery internship at Brooklyn Hospital Center and then additional 4 years in Washington, D.C. So, there's no one who could possibly love it more than me. So I'm very happy to have an opportunity to share my expertise with you all. And I'm looking forward to your questions and your camaraderie in the future. Tonight, I will be discussing thinking outside of the socket. I titled this because although our frame of mind is always and continuously inside the socket, sometimes it's important to take a breath of fresh air, lift your head, and think outside of the socket. So I hope tonight to bring some things to your attention that maybe you didn't even consider before. Maybe you weren't even aware of because you've been so tunnel vision in the socket. So let's step outside. And thank you again for allowing me to speak this evening. Again, my name is Dr. Julia Jackson. I'm an oral and maxillofacial surgeon. I am happy to be celebrating 15 years as an oral surgeon in private practice, and more recently starting International Implant Institute, which is a continuing education program really to teach general dentists such as yourselves how to do surgical procedures. I feel as though if I was a general dentist, I'd be right in this seat, trying to learn more, wanting to be better, loving surgery from the bottom of my heart, even if I was a general dentist. It's really a pleasure to have had the opportunity to have the academic achievement of becoming an oral and maxillofacial surgeon. But I know that we all have dentistry in common, and our surgical skills just really need to be refined and tuned because dental school keeps us from realizing our true potential. And so I hope tonight to open your eyes to what you all are capable of. So you see me there in my playground, my best place in the operatory. One on the bottom is in Manassas, and the one on the top is over in Annandale, Virginia. But you couldn't drag me out of this room if you tried. I probably have some music going, and my assistant is ready. Some of my procedures are under sedation, not all of them. So I do want to teach you how to do procedures awake and sleeping. I don't feel like you need to feel intimidated or overwhelmed that the patient will have any kind of anxiety. It is your job to set the stage. And so this is my best foot forward right here in the operatory, ready to go. That is, someone took a picture at the perfect moment of an extraction. A traumatic extraction. And so that's where it all begins. An atraumatic extraction is the beginning and the start of making sure that you have the most positive output of this type of procedure. You have to start with an atraumatic extraction. Nothing is impossible. Look carefully. You see this tooth. It's non-restorable. It's in terrible condition. It's missing more than 50% of the crown. Do not be deterred. This is nothing to keep you from taking this tooth out. If I can take it out, so can you. I want you to keep an eye on the fact that posterior to tooth number 19, you see the small little circle of gingiva that has been removed. We use a punch biopsy to remove that gingiva. In this situation, that is going to come into play. So keep an eye on why we remove that soft tissue, and I will certainly reference it as we go along in our presentation. This patient is sedated. Do not be overwhelmed or concerned by any movement or noises that the patient makes. Make sure you focus on your plan of removing this tooth. Absolutely atraumatically. Systematically, you're going to use your elevators, moving the tooth more distally, always elevating posteriorly. You are going to make sure that you have the patient's mandible parallel to the floor when you're taking out mandibular teeth, and have a firm and solid hold onto the mandible. You then grab a hold of your mandibular forceps, number 23, and you gingerly move them up and down in a pumping motion, left to right, buccal lingual, but more importantly, getting those forceps down into the furcation. And lo and behold, with your constant movement of the forceps, you too can remove this tooth atraumatically. It is absolutely very important that you make sure that you're not chasing the tooth, but in fact that you have everything stable, solid, and immobile, so that the only thing moving is the tooth, and you can confirm that you have bodily movement. I'm going to play it one more time for you. Nothing is impossible. Again, posterior distal movement and elevation of a non-restorable tooth, making sure that the mandible is parallel to the floor. If you're taking out maxillary teeth, and you'll see in other procedures during the course of the video that for maxillary teeth, you have the patient put their head completely up so that you can see every tooth in the maxillary arch. In this patient in particular, he is sedated, so there's a Mott's mouth prop keeping his mouth open. There's the sweetheart retractor holding the soft tissue, and there's also a gauze. I'm a stickler about making sure that you protect your airway. And again, you're holding your finger, that's my finger, on tooth number 19, feeling and palpating distal movement and bodily movement. Atraumatic extraction means that you can't just jump in and grab the forceps, kind of like when delivering a baby. We have to make sure the baby gets down into the canal before you grab a hold of it. Make sure that the tooth has mobility before you even attempt to remove the tooth. Again, you're grabbing your 23. I generally use a 150 for all maxillary teeth. I can use a 150 forceps to remove mandibular teeth. And to be very honest, I've never, if not ever, used a 151. Just doesn't work well in my hands. I can use ash forceps for mandibular teeth. Once you have a solid hold on the mandible, either you or your assistant must be holding on to the mandible. You grab your forceps, get it down gingerly into the furcation, and you take the entire tooth out in one fell swoop. And be sure you keep intact your interradicular bone so that you can eventually place your immediate implant. Thank you for watching, and I hope you get the idea of atraumatic extraction is how you start the process. Then you move on to socket grafting. Atraumatic extraction is a must. You absolutely must take the tooth out with as little damage as possible of your anatomical boundaries. Be cognizant that you have maintained all host bone, even if that means that you take a little more time Even if you start to feel the sweat trickling down your back, your assistant is tapping her foot and his foot and wondering why you even got involved with this extraction that was a non-restorable tooth. Why didn't you just refer it out? Block it out. They are not part of what you're meant to do. You can take teeth out, but you must take your time and feel as though this is your stage. There's no reason to rush, feel hurried, or to feel anxious in any way. Degranulate, degranulate, degranulate. Any granulation tissue remnants can spell doom for your graft. Irrigate, irrigate, irrigate. So the key to pollution is dilution. Occasionally, if not all the time, I will use a 50-50 mixture of normal saline and hydrogen peroxide. There are some studies that show that there have been some question of what the hydrogen peroxide does to the graft material, but in my hands, it has been 100% successful. And the reason I'm using the hydrogen peroxide is because it really identifies and brings to your attention the granulation tissue that you may not have seen, or that could be hidden, or that could be at the most apical portion of the socket, or could be in the there. Sometimes there can be infectious material and granulation tissue in between the interradicular bone. The hydrogen peroxide almost puts a spotlight on it. As they say, even Stevie Wonder could see it. So you want to flush with your hydrogen peroxide 50-50 mixture. And then, of course, after, flush with just 100% saline. Blood is your friend. If the socket is not bleeding, make it bleed. Curette, getting this bone off of the edge of the apical portion of the of the socket surface. So you want to use a curette to kind of generate some blood flow, get things kind of moving in that area. If necessary, small perforations with a drill to also stimulate blood flow. No tension on your sutures. The sutures are not there to pull the edges or flap together. We had a saying, we want to approximate, not strangulate. So it really is okay if the wound edges are just passively laying across your socket, or quite frankly, you'll see sometimes they're not even in contact. You just want to put them to there as close as they can so that eventually the soft tissue will heal. The two most important adjunct implant surgical procedures, quite frankly, success at these two techniques and continued improvement will increase your comfort success with all types of surgery. Grafting technique can make implant surgery easier, more predictable, and more profitable. I do want to accentuate this evening how important it is to graft, quite frankly, every socket, because it will give you predictable results in the event that you're going to be placing an implant. So even if you're not placing an implant, you should be grafting sockets. I am a strong believer that socket grafting is something that will only help the patient in the future, in addition to it being a lucrative procedure to help you in your business. But most importantly, it will give predictable results of bone being present in the future. Indications for grafting include buccal plate is less than 2 millimeters. So you bring your attention to the bottom of the screen. You can see this is a sagittal view on a CT scan where almost all of the buccal plate is missing. Usually in the anterior, the buccal plate can be missing when we're talking about a tooth that is not completely surrounded with bone. And this would be an absolute indication for grafting. You take the tooth out, you want to graft the socket for future implant placement, or more importantly, graft the socket so that the atrophy that started is no longer the only bone that will be present when the tooth has been removed. We know that the most ideal time, or when we have the most maximum bone, is when the tooth is present. So at that time is when you should be grafting to also add to the bone that's present. Another indication would be where sites where maintaining volume is critical to minimize the risk of involving anatomical structures, such as the posterior maxilla. So we're looking on the top view of a CT scan. You can see the sinuses. It does appear that there's limited amount of bone in the maxilla. And so this would be absolutely a site where you want to graft the socket. You can see the socket at the bottom, which is a maxillary socket. You want to be cognizant that you're putting bone graft material into all 4 of the sockets. You also want to graft the area when we're talking about posterior mandible. I am a strong believer that you would be grafting sockets number 31 and number 18. When we are thinking about an immediate implant, we know that the implant needs to be in native bone. Well, we know anatomically that the inferior alveolar nerve runs high posterior mandible. So tooth number 31, the inferior alveolar nerve is closer to the apex of the socket than in site number 30. So 30 would be a better space for an immediate, and site number 18 and 31 would be a better spot for grafting for future implant placement. In addition, patients with high aesthetic demands, such as high lip line or a thin biotype, which is prone to recession, even if they're not going to have an implant. So in this particular slide, you can see the patient is going to have an anterior maxillary tooth removed. They may be telling you that all they have in their budget is to get a flipper. But you and I know as practitioners that flipper is going to drive them up a wall after a while. You can't chew and function with it. Sometimes it affects the way that people are speaking. So although on the forefront of their mind is not an implant, you must graft the socket at time of extraction, even if they're not thinking about an implant then. For the sake of grafting this socket and perhaps having an implant in the future, you definitely want to put bone graft in the time of extraction. This is the time where we would have the most bone to work with, so that we have full bony walls to place bone graft material. In addition, the soft tissue hasn't tethered down and hasn't been shrunk and will be hard to manipulate after the healing process. So even if your patient is thinking that they're not going to get an implant now, you should be grafting the socket for future implant placement and predictable results. And that's how you want to bring it to their attention. They may say something like, well, why do I need to graft it if it's going to heal on its own? We are grafting so that we can have predictable results in the future. And that gives them an understanding of how important socket grafting is as well. Everybody wants predictable results in the future. In addition, indications for grafting include in a patient having multiple teeth extracted and preserving the bone for restorative needs. I have a diagram here. When I teach my classes in International Implant Institute, we usually have some type of demonstration models or ways that people can visualize exactly what we're talking about. When we do know that at time that there are teeth present is when there's going to be most bone, and then systematically there will be degrees of atrophy by the time we get to the point where we just have a small atrophic mandible. It's too late to be thinking about grafting. At that point, the soft tissue is tethered down. At that point, it's hard to manipulate the tissue or even have space for the bone to be placed. If you are looking at a CT scan and every tooth is periodontally involved, they're moving, they're looking in terrible condition, you should be discussing with the patient. Although they may be getting a full lower denture, eventually that bone will atrophy, and we do not want them to have a full lower that they can't wear or use because the mandibular denture is rubbing on the inferior alveolar nerve and the mental foramen area. So graft the sockets for full mouth extractions, graft the sockets at time of extraction, graft the sockets when you are in an environment of taking a tooth out. Always be aware that socket grafting is a adjunct procedure that will be especially helpful to your patients. Classifications of the materials based on the mode of action. A little bit about myself. I was never a very good test taker. And even early in my elementary school, having a little difficulty even with reading. But as I've studied and learned and moved on in my academics and achieved the highest position of oral and maxillofacial surgery, I feel it is, I've realized that sometimes getting a picture in my mind helps me understand the best use of the words. So I'm going to try to make my descriptions here visual to your mind as well, and perhaps you'll be able to gather the information. Osteogenesis. So we know osteo, bone. We know genesis is the beginning. So osteogenesis refers to the formation of new bone from living cells transplanted within the graft. So this is the beginning of how bone is going to start. These are all the cells that are necessary so that we can build bone. Osteoinduction, I think of this as the cells that are added. So osteoinduction refers to property of material to induce. So we're bringing extra cells into the area to only further help with osteogenesis, to induce differentiation of undifferentiated pluripotential cells toward an osteoblastic phenotype. So we want material that is osteoinductive, which will bring new cells in to help with our osteogenesis. And osteoconductive, I think of as conductive, kind of like construction. So when they're building buildings, they put this scaffolding around the building, and then they can add a brick and add a brick and add a brick. So you have to have the scaffolding first so that then you can have the bone to become viable. Osteoconductive material is analogous to a scaffold or framework into which existing bone cells may grow. So I even explain that to the patients. I say, we're going to add bone graft material that's kind of like a scaffolding, then your bone will permeate through and everything will become solid. I just try to put it in pictures so that even the patient can kind of picture, oh, okay, I understand what's going on and why we need to add the graft material. Classifications of graft materials based on the source. Autograft refers to a transplant of viable cortical canthallous bone from one location to another within the same patient. So let's bring our minds back to the video that I played twice with the music. And you remember that there was a small circle that was punched out of the soft tissue in site number 18 in distal to tooth number 19. The idea there is that, yes, we want to utilize that punch biopsy tool, keeping in mind all of our anatomical boundaries, utilizing our anatomy as our guide. So sometimes I will have the patient close their teeth together just to see how does the maxilla occlude with the mandible and where are the cusps that line up. I'm a 99.9% freehand surgeon. That's because that's how I was taught. We didn't have guides when I started. So I haven't ever needed to rely on a guide. And so what do we use as our guide? We use our current anatomy. You have to use the patient's anatomy to know where you want to place your implant And then, of course, it is prosthetically driven implant placements. So I digress. When we punch out the soft tissue, we have identified where does it sit in line of the arch, and then we would take out tooth number 19. The next step is that you will place your implant number 18. Clearly, that patient had enough bone between the apical portion. It was an edentulous space, so it had enough bone and wasn't involved with the inferior alveolar nerve in any way. And so you start with your pilot drill and then your next drill. And what you see at the bottom is that we will actually scrape off autogenous bone graft material from our drill bit. So you have to be thoughtful here. You have to be thinking, okay, first I need to harvest bone from 18 so that I can place it in socket number 19, but I'm going to take out 19 first so that then at this point I know exactly my order of operations. I made my punch of 18 first, and then I'll take out tooth number 19. The gold standard for bone graft properties, but requires second surgical site. The way that I'm teaching you is the second surgical site is just simply number 18. You can harvest bone graft material from 18 to place into 19. But also as oral surgeon, we sometimes harvest from the hip, tibia, ramus, chin, or other osteotomy sites. Sometimes the symphysis. Allograft refers to transplant within the same species, such as use of demineralized freeze-dried human bone or freeze-dried dermis in human subjects. I would like you to bring your attention to the little well at the bottom of the page, at the screen. You can see that there's a speckle of red. That is the bone graft material or the bone that was harvested from the drill bit. And then we simply add it to the well. And then we mix in all of our bone graft material so that now you've added your autogenous graft to your allograft. And at that point, this will be a site that will allow for osteoinduction, conduction, and osteogenesis. Xenograft refers to cross-species transplantation of tissue, the use of an organic bovine or porcine collagen in humans subjects. So xenograft is taking bone graft material from other species. Bovine, of course, is cow bone, and porcine is pig bone. Some people have religious preferences. Some people have their own reasons, not religious, as to why they would be agreeable to xenograft or not agreeable. Alloplastic grafting material, I'll be very honest with you, is very expensive. I personally feel like it's limited in its use because it is not very helpful when for osteointegration. So quite frankly, this would be used more for our atrophic mandible, where we know the patient is going to be having a full lower. And in fact, we really just want to have it as a space maintainer to keep the mandible from becoming more and more atrophied, degrees of atrophy over time. But I put it there so that we have a comprehensive understanding of all of your bone graft sources. Again, autograft will be absolutely the best, osteogenic, osteoinductive, bringing in other cells, osteoconductive, also utilizing scaffolding philosophy with regards to allowing for the bone to permeate through. Allograft, osteoinductive and osteoconductive. Xenograft, specifically osteoconductive, again, a scaffolding to allow for the patient's bone to use and then to build on. And alloplastic, osteoconductive and osteoinductive. And of course, last but not least is our membrane. The barrier membrane is really just a small piece of square material. Frequently, I will place my membrane in saline solution so that it's more malleable. I prefer it to be malleable. We know the epithelium will heal faster than bone, so we want to pack our bone graft material completely in the socket, leaving no voids, no defects, no spaces that haven't been packed completely, even down to the most apical portion of the socket. And then you place your membrane over top, tuck it into the edges of your socket, and then suture over. It is utilized as a space maintenance to maintain and to rebuild lost bone. It maintains the graft, especially on the maxilla. If I'm grafting socket number 4, then I will put my membrane there to make sure that no bone graft material falls out. I always tell the patient they can't hurt themselves, they won't damage anything. We do anticipate that over time it will start to resorb and disintegrate, and also our sutures will resorb and disintegrate. It's utilized really just to keep the clot formation. So quite frankly, I have had some patients who will call, I don't know, 3 or 4 days later, and they say, oh, it fell out. That's really okay. It was there long enough. Don't be discouraged. Don't feel as though it hasn't been useful. It did its job for the point of keeping the clot in, at least for the first hours of clot formation. Different resorption rates and different handling characteristics depending on which kind of barrier membrane is utilized. Okay, let's put everything together. I'm going to give a few examples of when to socket graft and to show you exactly when I think it is most useful, and also the technique itself. So this is a patient that had a root canal. And so we need to take out a root canal tooth. Again, do not be nervous that it's a root canal tooth. Do not refer this tooth out. You can do this. You're thinking that if you take the tooth out, either you can graft the socket completely for future implant placement, but in this situation, I am going to take a step on the wild side and show you an immediate implant placement and my own technique of how it can be very successful, and then also placing the membrane with closure and a post-op x-ray. This one doesn't have music, but I will talk as it goes. This video is real time. Again, take your time. Do not rush. Make sure that you are holding on to the maxilla with 2 fingers. You want to have digital pressure on the buccal, digital pressure on the palate. You also have the patient in the up sniffing position, completely up in the air. You'll actually see, if you look very carefully on the other picture to the left, you can actually see right up her nose. That's when you know you have the patient in the right position. You cannot break your back, folks. You cannot be leaning over, struggling to see, trying to hold on. This person is laying in a chair. Make them lay as far back as possible so that you have the most visibility. Do not hamper your ability because of their comfort. You have to be focused on the priority that your job for the day is to take this tooth out atraumatically. Also be mindful that there is a crown on tooth number 12. So we are not trying to take out the crown. My finger on my thumb on the palate is actually holding on to that crown just to feel if there's any movement, any slight mobility, just to be aware that that tooth is completely intact and the crown hasn't been damaged in any way. My favorite instrument, it is called a universal upper 150. I personally use it on all maxillary teeth, and I also use it on mandibular teeth. It fits very nicely in my hand. You should try it before you balk at it being used. Quite frankly, I never use a 151. It's not even on my tray. I use a 150. I can use a 23, and I'll use an ash on the mandible, only on the mandible. But again, taking your time, making sure that your forceps is as apical as possible. Quite frankly, I'm not even really concerned about the buccal bone. I know there's a periodontist in the world today who would be upset that I say that, but I'm saying it to you because, quite frankly, I'm going to be placing this implant palatally. This socket is shaped like an oval. So we know that the implant is going to be more to the edge of the palatal oval than to the buccal. The buccal opening will be completely filled with bone. So even if I did have a buccal plate removed, which you will see carefully that I do not, I'm not really that concerned because I'm going to be grafting the site anyway. And as you see, gently moving the instrument, you are in complete control. You're not letting the patient's head move. They are stable and sturdy. You have a good grip on your forceps, most apical portion of the root. Again, not concerned that this is an endo-treated tooth. When we don't psych yourself out that it's going to break, just keep moving. And there we go. Tooth is on the table. I mean, I don't know how long it took. Perhaps you feel like I talked a lot while it was coming out, but I'm not in a rush. And I really don't think that you should be either. Take your time, hold on, and enjoy the extraction. Next, on the one moving on the far left, this is with the pilot drill. I not only have the pilot drill on the handpiece, but I also have an extender. You see the patient's nose, so you know that their head is completely up in the air. I can't see directly into the extraction socket, but I can feel with tactile sensation that when I place my pilot drill, I'm going to be leaning it onto the palatal wall. That's again why I'm not really concerned with whatever's going on the buccal. I wouldn't want to make myself feel like I couldn't do it because there was something going on with the buccal. I want to focus on what do I feel on the palate. I'm going to run the second one. As I continue to go on with my surgical drill sequence, I then sometimes change my drill bit to not have my extender. It really depends on how wide she can open. But as soon as I've used my pilot drill to at least get my purchase point or my starter spot, then I can utilize my drill bits. It will fall right into the osteotomy. So sometimes I don't need my extender as I'm going along my surgical drill sequence. I'm also a strong stickler about throat packs. So you'll see me put the throat pack in, take the throat pack out, especially with small pieces and parts and drill bits. And eventually you will see me also utilize the paralleling pin. I'm going to go back just a little here on this one because I want you to see that the graft material is being prepared by the assistant. We put the particulate matter works best in my hand, and I will show you how the particulate matter works. You add the saline to it, you mix it up so that it's a little bit more easier to manipulate. It's going to start off as sand at the beach. When you add the water, then you can make it a little bit more clumpy. If you look carefully, this is a technique that I use all the time. I don't want to say I invented it, but I do this all the time. And I'm not really sure if I saw it happen, but I'll tell you this. I had a issue. The issue was if I graft the socket and then I try to come in with the drill and drill the osteotomy, all my bone graft is going to come out. If I put the implant in first,
and try to graft around the implant, well, the idea is you're not supposed to really touch the surface of the implant. So how can I really get into all those little nooks and crannies and make sure that I have a completely filled socket? So I thought, how can I make sure that I can have both? And so I'm going to run this one just a little bit. You'll see that I actually placed the paralleling pin into the into the osteotomy, and I stick it in firmly. I feel it that it's firm and solid into the osteotomy that I just grafted. That I just placed palatal to the socket. And then with meticulous precision, I graft around the paralleling pin, even utilizing a perio probe to make sure that I get down into every groove of that socket, even down to the most apical point. And again, you can see this is why I'm really not that concerned with any buccal plate. If there was an issue, believe me, at that point, I've put enough bone in that buccal area to not be concerned if there was any kind of buccal defect, because the graft will be filling in any defect. I also graft palatal to the pin. Sometimes the pin goes all the way down into the palatal osteotomy, and there may be just a little bit of space between the pin and the palate, and I want to make sure I'm grafting everywhere. So this technique really solved the problem. Do you graft first or do you place your implant first? This technique gives me 100% success that every implant I place is 100% covered completely. And of course, you can just imagine at that point there, totally grafted buccally, totally grafted palatally, mesially, distally, and the only thing left is the pin. And so, of course, the next step is to pull the pin. So with gingerly, I try not to pull just the string, but I can sometimes pull the pin. And now I have an osteotomy like no other, quite frankly. It's human made, but it is exactly where it's supposed to be, especially compensating for the fact that the socket is oval and your implant is going to be cylindrical. I come in with the extender. I have my implant set and ready for placement, and I will place it in. I'll check for making sure it's torqued completely on my motor. I will have the patient close to verify occlusion. I will gingerly remove the driver from the implant platform. I will not have the assistant suction in there. I can see the platform very carefully. And finger tight, I will place the cover screw. And then sometimes either just moving some of the excessive graft material over the cover screw, or maybe just the last little bit of graft material, I will completely submerge my implant into that socket. Last but not least, I'm going to run this one. I have gotten my membrane soaked and malleable. I will contour it to fit perfectly into the socket. Sometimes my assistants are very helpful for that step. They love to contour the membrane. And then, of course, last but not least here, we will place the membrane, and then we will suture the wound close. Again, suturing and socket grafting are very good adjuncts procedures to implant placement. Again, suturing can sometimes take longer than just taking the tooth out. I see our time is running with regards to the presentation, so I won't belabor the suturing point, but you can get the gist that eventually I will put an X marks the spot over this membrane and securely fasten the membrane into the socket. And there's our post-op. So we can see that it started off with a tooth that was just close to the sinus. And of course, our implant is exactly where it's supposed to be. Believe me, I discussed with our patient about placing the implant on the mandible. I drew the picture, discussed it with her so that they can be thinking about also restoring the mandible. I'll keep going. This one is failed implant ridge augmentation. Bear with me. I take the photographs of my patients while I'm doing the procedure, while the music's going, while everything is moving. So this one, there's some pictures that are a little fuzzy, but I think you'll get the gist. This is an implant that is clearly failed. There's food, debris, calculus around it. Doesn't appear to be in good condition. And so the patient has come to have the implant removed. Upon removing the implant, we can see that there's even more room than meets the eye. I was able to remove the implant. You can see the ash forceps in the middle of the two pictures, really just rocking it out and taking it out. Once we degranulated, irrigated, full thickness flap, make sure things are healthy and clean. I want you to zoom in on this picture on the top right, specifically that it's small increments of bone graft, very small, just to put them first into the site where the implant was. You don't want to come in with the clump first because you can have a void at the apical portion of this site. Be sure to start with small pieces of bone graft. That's why I use particulate matter. I did bring to show you all that sometimes you can utilize a plug, but it works best in my hands to use the particulate matter, every little morsel of the particulate matter. I filled the area completely. On the top left, you can see it's just starting to be filled. Fill it completely, and then I put my membrane, tuck it in on the lingual, tuck it in on the buccal, and then suture the area closed. Again, this is the before and after, bottom right, implant removed, and quite frankly, now on the image on the, bottom left is with the implant previously there, the failed implant, and then on the bottom right, where it looks as though this is a site for more than one implant to move forward. And clearly this is an implant patient. She knows about implants. She has multiple. Traumatic extraction number 18, socket preservation. Inferior alveolar nerve. Again, this is a patient where the inferior alveolar nerve is running high. He is not a candidate for an immediate. The socket is open. Tooth is removed. This one you can be a little more generous with your graft. I come in with a big scoop and then I'm placing it in with increments, pushing it down, making sure it's against all boundaries, borders, and walls. I hope not to be redundant, but I just want you to see this is really not that tricky. It is certainly a procedure that any of us and all of you can absolutely do as long as you take your time to place the bone graft material. It's good to the last drop.